Good afternoon, ladies and gentlemen. Dr. Takimo, Dr. Roger. It's a great pleasure to be here and to discuss with you our experience with the use of homografts in pediatric age groups. We all know the characteristics of an ideal valve substitute, that it should be durable, it should provide the patient with normal hemodynamics, should be non-thrombogenic, not requiring anticoagulation, silent, infection-resistant, easy to implant, and readily available. And we know that such a valve basically does not exist, and we believe that the autografts are probably the closest, but of course the homografts can be very close. We've heard about the history in the previous talk, so we'll skip that. And I would say that at the present time, the allografts or the homografts are generally, in any situation, are dissected under sterile conditions and then sterilized in antibiotic solutions, and then they can take either one of three tracks. They can be kept at 4 degrees centigrade in tissue culture medium, and these are what we refer to as the fresh antibiotic preserved homografts. Then they could be cryopreserved and then kept at liquid nitrogen, generally a bit around minus 80 degrees centigrade. And then this is a special group that's called the homovital. This was basically introduced by Dr. Yaqub in London, where the homografts are harvested from brain-dead multi-organ donors or heart transplant recipients and kept unprocessed at 4 degrees in tissue culture medium, containing very small doses of penicillin. And these are usually implanted very early on, mostly within 4 days of harvest. So if we look at the homografts, we can either have an aortic or a pulmonary homograft or a mitral and tricuspid. And of course, we know that the aortic and the pulmonary homografts are the most commonly used. The mitral homograft has got little use at the present time, and the tricuspid, hardly any use, and mostly some segments of the tricuspid valve can be utilized for reconstruction of the mitral valve, particularly in cases of endocarditis. The mitral homografts have been used for mitral valve replacement, and that's total and partial. They can also be used for tricuspid valve reconstruction, and these have been used mostly in adults, not in children. Technical problems were very significant, and the results in literature have been very variable. Dr. Ecker in France proposed a technique and standardization of sizing, which seemed to have produced consistent results initially. However, with longer follow-up, results became discouraging, and actually very few surgeons at the present time use mitral homografts. However, partial mitral valve replacement remains an option in mitral valve reconstruction. We go to the aortic homografts. These are used for aortic valve replacement. They are also used for pulmonary valve replacement and right ventricular outflow tract reconstruction. In congenital heart disease, they can also be utilized for mitral valve replacement and for tricuspid valve replacement. The commonest use of the aortic homografts is in the replacement of the aortic valve, and this can be implanted as a subcoronary implant or as a full root implant. And as such, it has been an excellent aortic valve substitute with near normal hemodynamics. And this is just a graph looking at the survival of the homografts. You can see that the cryopreserved do a little bit better than the antibiotic preserved homografts. And this is the homovital group, which has some viable cells, and you can see the expectation that they're better than the antibiotic sterilized or the fresh homografts. And in terms of resistance to endocarditis, you can see that the mechanical or bioprosthesis, they have an initial hazard of being infected. However, the homografts remain with a very low risk right from the beginning. So the aortic homograft are really used as an aortic valve substitute in children because of the early degeneration, and this can be related to active metabolism and growth. And actually, in one of our patients where we replaced a truncal valve with a homograft, we reported an accelerated degeneration within 6 months of the initial surgery. And this was really a very rapid degeneration of an aortic homograft in children. However, we have had a better experience in using the homografts to replace the mitral valve. And of course, for this, it is placed inverted inside a dacron tube. And this is what we call the top hat technique that was described by Dr. Yaqub. And you can see that the homograft is placed inside a dacron tube. Then this is the hat, and then in the top of the hat is a pericardial patch. And this is how the valve is sewn to the mitral valve annulus. And then this pericardial flap is used to form a new floor for the left atrium. So mitral valve replacement utilizing this technique, as I mentioned, has been used in pediatric age group with reasonable success. However, durability remains a major issue. And looking at our own patients, we have used the aortic homograft in the aortic and mitral position in pediatric age groups, aortic 15, mitral 8. And if you look at actually all of these have been explanted at the present time. And if we look at our own pediatric patients that's around below 15 years of age, you can see that the bioprosthesis, aortic valve, mitral valve bioprosthesis, and we can see the homografts in the mitral and in the aortic position. So the mitral valves or the aortic homografts in the mitral position really did not do very well. And as I mentioned, all of them have been explanted. They've done a little bit better with the aortic position, but there is no doubt that the stented or the standard bioprosthesis have done better in the same age group. The aortic homograft also, with the same technique, the top hat technique, we have used to replace the tricuspid valve in children, and we found this really very, very useful in some children. And I mentioned here that pulmonary homografts can be used in this position as well. And the results in the tricuspid valve position have been very, very encouraging. But this is really technically very difficult, and often more than not, we find that it is necessary to enlarge the atrial septum to be able to accommodate the homograft. And of course, the advantage is you can use a larger size, and because you're putting it inverted, the valve sits in the right atrium and does not go into the right ventricle and cause any problem in the right ventricle or in the right ventricular outflow tract. And also we find that the coronary sinus have to be diverted to the left atrium. Therefore, we in the latter period in the experience, we really eliminated the top of the hat, so there is no pericardium. And this is the classical top hat if you look at it cross section, and we just leave the homograft inside the dacron tube standing up within the atrium. Actually, we've had 2 patients that required reoperation, and surprisingly, there is a little bit of smooth thrombus formation in here, but really it has not caused us any problems, and the valve seems to function very well. So really, this simplifies the procedure. And also, for those who know the ROS2 procedure, where the autograft, the pulmonary autograft is used to replace the mitral valve. And as we know, the largest experience comes from Syria, Dr. Gabbani group. They also have stopped using the pericardium and again leave the autograft standing up in the left atrium. Occasionally, in patients, very small patients, where the tricuspid valve annulus is very small and there is nothing you can do, one can use an aortic homograft as an extracardiac conduit, like in this patient who happens to be also dextrocardia, where the tricuspid valve was very stenotic and nothing could be done, so we did an extracardiac homograft connection with a good outcome. The aortic homografts are also used to replace the pulmonary valves in right ventricular outflow tract reconstruction. And results have been as good as the use of the pulmonary homografts in this position. However, there is some groups that believe that the aortic homograft does not produce as good results in the mitral position as the mitral homograft, and they discourage its use. However, in our own experience, both aortic and pulmonary homografts used for the right-sided reconstruction behave more or less the same, and there was no difference in the long-term outcome. However, the aortic homograft has the length advantage that is occasionally needed in patients with complex anatomy. For example, patients with LTGA, where an left ventricle to pulmonary artery conduit is needed. This is usually a very long pathway, and an aortic homograft generally gives you that advantage more than the pulmonary homograft, which if you use, you have to extend. When we go to the pulmonary homograft, the pulmonary homografts do not sustain pressure as well as the aortic homograft, and therefore, and you heard this in the previous talk, attempts to use them in the aortic position as aortic valve substitutes have resulted in a high rate of early structural degeneration. So pulmonary homografts should not be used as substitutes for the aortic valve. And similarly, we believe that they should not be used for the replacement of the mitral valve in the top hat fashion that we described. It is feasible to use pulmonary homografts for tricuspid valve replacement, and this is logical. It's a lower pressure system, so they should be able to sustain the right side of the pressure. However, the commonest use for the pulmonary homograft is as a substitute for the pulmonary valve, and we believe that in this position they are the conduit of choice. We use them after congenital procedures, after the Ross procedure, and of course it can be implanted during the primary procedure or subsequently in cases of RV failure when a non-valved connection technique had been utilized in the initial operation. And as we all know, the indications and timing of pulmonary valve implantation under these conditions is crucial and being extensively investigated at the present time. But as a principle, it is always better to intervene before significant RV dysfunction develops. Generally, there has been a low incidence of valve-related complications using the pulmonary homograft in right ventricular outflow tract reconstruction, and is considered superior to other available conduits. Though some commercially available conduits like the Contigra are reported to give comparable results. However, I must say our experience with the Contigra have been in a way not as good as it has been described by many groups. This is a Contigra 12 millimeter conduit that was used in a neonate that has calcified within actually less than 6 months after implantation. And also we noticed this, that in patients who have some obstruction distally and end up with having a high pressure proximally, the Contigra dilates significantly, like in this patient who had about a 9 centimeter aneurysm after a repair of tetralogy of Fallot, where there was a distal pulmonary artery obstruction and the Contigra conduit really dilated significantly. The pulmonary homograft, when used as a pulmonary valve substitute after the Ross procedure, generally lasts longer because it's in orthotopic position, and also because there is a normal pulmonary vascular bed with generally normal pulmonary vascular resistance. And in our Ross series, the freedom from homograft replacement was 88 plus minus 4 at 10 years. And we noticed that the cryopreserved homografts performed a little bit better than the fresh antibiotic-preserved homograft. But nevertheless, all homografts will ultimately fail and require re-replacement. And re-replacement with another homograft is possible. And the second homograft performs as well as the first, and this has been studied and reported. As you can see here, the actuarial survival between the first and the second replacement is basically the same. And then the freedom The event-free survival is again more or less the same between the first time and the second time replacement. And the fear that there might be some sensitization from the first homograft is really not there. So if we look at the immunologic aspects of the homografts, there is no doubt that there is likely an immunologic response, and this is mostly related to some viable cells within the homografts. But this immune response, it's really not clinically significant, and in general, the ABO compatibility was not felt to be necessary. However, the Swiss group led by Dr. Christensen believed that the homografts do have, if they are matched with ABO compatibility, then they behave better than the other homografts, and that they believe that they believe that the blood group should be respected in implanting the homografts. Our practice currently is to try and match, and if we cannot, we just proceed as usual. So the last question that remains in terms of immunosuppression, if in that regard is the use of immunosuppression justified? And we looked at this role of cyclosporin in that regard, and actually we did a pilot study looking at the use of small dose cyclosporin in children, and although the cyclosporin failed to show a difference in echocardiographic homograft degeneration, it may decrease the need for reoperation. And we're just trying to embark on a larger group of patients to see if that makes any difference. It is also recommended by some groups to use non-steroidal anti-inflammatory agents like the ibuprofen to prolong the homografts and reduce this problem. Just to finish off, if we look at other factors that may contribute, and these are just technical tips to improve the survival of the homografts, young age at correction is a contributing factor, smaller body surface area, tension on suture lines, use of aortic homografts, early postoperative fever, and generous oversizing. Thank you very much.